sure I can get it to work before we get going. Lovely, so nice to speak to you all, and hopefully, I think I've met lots of people in the room, but not everybody. So I'm a paediatric neurologist working in Leeds, and I've had the fortune to train under Professor Livingston, who was, prior to our national service, the unofficial head of paediatric white matter disorders in the UK. So I've been working within white matter for a really long time, unofficially, and now in a much more official aspect. And I think it's about taking our experiences and channeling those to our patients wherever they are in the UK. So I'm going to talk first about the service, and then Rahul's going to talk about the registry, if that's okay. So, leukodystrophies, these are not just rare diseases, these are ultra-rare diseases. They affect less than 0.1% of people in the population, and that makes it really tricky. The more we know about a disease, the more we can think about it when we see patients at presentation, the more we know about how to diagnose it, the more we can talk about the future and the prognosis. In rare disease, we don't have the answers to those questions, and even those that get a diagnosis or a label, we can't always be clear about those, but actually there's a huge cohort where we never get a definitive diagnosis. You are just a leukodystrophy patient, a white matter patient. What on earth does that mean for you, your family, your child? Now, these are over 100 genetically distinct disorders, and sometimes they follow patterns, and sometimes they're a bit more heterogeneous, so it's a bit difficult to tell you day by day, patient by patient, what you're going to look like now, next year, in the year after that. Many of them present in childhood, many are progressive, and many will be life-limiting. But that's not everything. We have our neonatal onset disorders all the way through to our adult onset disorders. So it's a really big spectrum of disease. But because of this heterogeneity, because of this rarity, diagnosis is often delayed. That affects access to specialist services, access to treatments, access to trials, but actually just access to an answer sometimes. And even if we can't do all of those other things, actually just having an answer is important. Now, in 2013, the NHS developed a rare disease strategy that really recognised that we need, as a country, to improve the service that we provide for patients and families with rare diseases. There was consultation with multiple agencies, including the BPNA, rare disease advisory groups, and this identified lots of unmet needs for patients within that group. And really this led to the commissioning, and I use it in one quick line, the commissioning of an NHS highly specialised service. That was a hard-fought battle over many years by my predecessors and many people through the medical professional, but also Alex TLC and Metabolic Disease UK communities, pushing that forward and making it from words into actions. So what are we? So we are now a national service. The funding is for a diagnostic service. So a lot of the money is based on how do we get you to a diagnostic test, how do we do the right test and get you to an answer. There is money for nurse specialists, which is amazing. We've got psychologists, we've got some genetics money, but they're small pots for quite a big task. At the moment, we're splitting ourselves across 3 sites for the paediatric centre. So there's the Midlands, the North and the South, and then an adult service with a central hub and then some spokes out throughout the UK, where all their patients are set up and coming through a centralised adult service. Within the paediatric centres, we have MDTs individually within our 3 sites, where we are neurologists, neuroradiologists, geneticists, metabolic consultants, nurse specialists and service coordinators. So it is a massive undertaking, and the model is channeling all that expertise through virtual MDT and review when we're referred in, and channeling that to their patients at their local communities. Now, we can see patients in clinic if they need to see us, but they don't all need to see us. You don't all need to travel around the country, but they might need support around testing, they might need support about management, they might need support around diagnosis, and then we can feed and filter that back locally. Because I think there's a big thing about, I need to see a neurologist, but what can I do for you in our 45-minute appointment that will change your day-to-day? Actually, what we need to do for you is enable your local teams, your local services, your community where you live day-to-day to provide the support you need. And we need to help them do that in a way that is relevant for you and your condition. Coming and seeing me once a year will not change your month by month, day by day. But if we can put that service and support in local to your home, that's where we see the benefit. That's where we're going to see what's making the difference. So some awful headshots of many of us. So from the paediatric service, we've got Rahul and Cheryl from the London team, myself and Deepak, and then Evangeline and Amitav from the Birmingham Centre, and then David down there on his own running the adult service. I haven't got our spokes in the other peripheral centres. I'll have to do that for next year. So there's lots of us, and outside of the service and running our individual sites, we meet annually to do from a supervision perspective, and then more frequently to talk about difficult cases. So this model of care is generic, but with some regional variation. We have MDT, referrals, discussions with that highly specialised MDT team, and then we document our outcomes. So it's really important that we're feeding back the discussion we've had. So was this a really clear answer and we've got a decision for you, or actually is there a complicated care pathway that we need to send you down, and can we do that locally? And then we're going to give you some advice, or we may actually bring you to clinic, and we'll do that depending on what your needs are individually. We have NHS England oversight, so we have a data submission annually, so we're tracking what we're doing, and that's really looking at key core outcomes that were predetermined. So looking at our caseload, the number of referrals that we're getting, those having MDT discussions, genetic testing, genetic counselling. So what is our service needing, and what are the numbers that we're seeing in those different areas now? And then annual review, where we're presenting our numbers as a national service and comparing what we do. As I've said, we all do things slightly differently, but it's important that we're trying to set the same standards for our patient regardless of where you are in the country. At those discussions, we talk about our positives, and we can and hopefully learn from those as a service and roll out change, but also the challenges and what learning we've had for each other as a team, and then focus on that wider service development. Now, we're now just 2 years into the service going forward, and we've made lots of progress, but I think now we need to use the next 12 to 24 months to think about where is this going to go in the future. So we're just going to talk briefly about our 2022 to 2024 data, which is about 18 months in the captured period. So this is just from our London service, so we've got 136 referrals over that 18 months, and MDT discussion year by year growing. And then number of patients were discussed multiple times in those MDTs, because actually often this isn't a one-stop shop. We want to give you some advice, we want to get new scans, we want to get feedback after our genetic results and see where we go from there. In terms of clinics, so we're seeing a lot of people virtual MDT review, some virtual clinics, and then a smaller number of face-to-face clinics. That's when patients will really value coming to see us in person. You don't all need to do that, because actually that's not how the model of service works. We want to do as much local care as we can with expert support. So positives. There were lots of positives in our annual review earlier this year in February. Growing numbers of referrals. There is perhaps a slight bias towards the South and the London teams, and we need to look at how we advertise and sell ourselves more peripheral to that, I think. We are developing referrals with our referral centres. And I think in Yorkshire, as a local MDT, we've had a really, really good buy-in from my local and regional DDHs, but it's been harder to really persuade the more peripheral, and particularly neurology centres. So I think when you've got a DGH with an IWMD, they're really keen to hand you over. But actually, if you've been under an experienced neurologist for 10 years with a condition, they don't want to send them to us. And I don't want to challenge that you don't need a local team, but it's actually, do we have something that we can add value for the patient journey? It's not about taking over care. And I think that has been a challenge, but we're getting there. We've had really positive feedback from families. And I think there's a small amount that as clinicians we add, but our service coordinators, our nurse specialists, the impact that they have on a week-by-week, day-by-day basis is huge, and we've had really positive feedback from that. So that's really nice to see. We've got collaborations with patient support groups that's been vital to making us the holistic care service that we plan to be. And then in the background of that, we've got the Leuco Labs Collaborative. So this is a research network, because when you're looking at rare diseases and diagnosis, I've grumbled next door about my genetics, we have the ones we know about, the ones we don't know about, and how do we close that gap and give a proof of new or novel disease genes. And without that research network, we're not going to be able to move forwards in an NHS setting. There have been positives in ensuring patient safety. So examples of these are where we've had, after diagnosis, parents and families reporting lots of different versions of events to lots of different people, because actually they're just going through one of the worst times of their life. And then you've got 4 different teams trying to answer 4 different questions for one patient and family. And that can be really confusing. So what we're doing is really detailed discussion and communication, setting out clear plans and feeding that back. So not just through the family, but through our nurse specialist, and making sure that we've got direct interactions and identifying the problems, and in this case, referring for psychology inputs and support, which hadn't been flagged, but you could just see the red flags from several different centres. And then lack of engagement. We've all had families where you've told them the worst bit of information that they've ever thought they would receive. Some families go, thank goodness, I've been waiting 10 years to hear this information. Other families close themselves off and disappear into the background. Now, we had one family in particular that I was extremely worried about, that they were deteriorating, and because it had been so difficult for the parents to accept the diagnosis, that actually the patient was coming to harm. And in that, we were able to reach out to the local team, identify a local paediatrician that was able to go in and do some of the assessment on my behalf, because they weren't coming to clinic, they weren't coming to telephone contacts, and actually now we're doing a regular at-home review every 3 to 4 months, and I don't need to see them as much anymore because we are in a better place. But last Christmas, last November, December, I was worried on a week-by-week basis because they just didn't know how to cope, and as a private family, we were just pushing on them. So you need to work it out on a family-by-family basis, how can we overcome that hurdle? There are challenges, and the undiagnosed patient is a big challenge. The access to research genetics is a big challenge, but we have plans now to put those in place. So from the start of next year, we will have a negative genome program pilot for the North patients, so people we have phenotyped within our service, and we're looking at how we can use whole genome data from the NHS setting in a research setting to try and expand our ability to pick up those undiagnosed or missed genes, but also the new and novel disease genes backed by the Luca Labs Research Collaborative to prove the pathogenicity of those, so to find those diagnoses that we've not yet found. Hopefully, we'll then roll that out nationally within 12 to 18 months if we've got proof of concept. There is a lack of standardised guidelines for the support, so if you have a common leukodystrophy, there's international consensus, there's a plan, there's a treatment sometimes. But what about our rare patients? What about our undiagnosed patients? What do we expect from our local services and teams? What's the minimum standard of care those patients should accept? Because we see families all the time, not everyone comes to us, but the ones that come to us tell us, well, I've been fighting for this, and I've been fighting for this, and I've been fighting for this. So what can we say as a service that this is what we want locally? If you've got a white matter disorder or leukodystrophy, let's get A, B, and C in place for everybody. It's not the same as doing it for a single disorder because these are different disorders in a big group, but there are some bases of care that if we can have a consensus statement nationally, we can then build on that from a community and local perspective. There is regional variation in what we do. My clinic runs different to Rahul's clinic, runs different to Deepak's clinic, and that is always going to be the case, but we need to have some similarity so that we're not getting patient postcode lotteries and ensuring that we're giving the same level of service, even if it's delivered in a slightly different way to our patients throughout the UK. We'll talk about genetics in a moment. And then finally, time. The challenge of time in all of our job plans, as you'll all be aware, there just isn't enough to do all the things you want to do. But we have to be honest about that and then think about, so what can we do in the next 12 months? What can we do in the next 5 years? Where do we want to go and where can we prioritise our actions? So this was something we presented in February, the inequalities of genetic testing around the UK. We had a freedom of information request to our different labs for the turnaround times of our R109 paediatric white matter panels. It's great if you were in Cambridge, there was a 0-week turnaround. I'm not entirely sure that was because they hadn't done any, or we'll never know. But you can see that in my service, we were looking at 2.5, sometimes 3 years for some of our patients. And that's just because the lab is short-staffed, the lab is busy, but why do my patients have to wait 3 times longer than somebody else? So we're now in a position that A, I've complained about this and they're doing a little bit quicker for me, which is always a good start, but we have choice. So where am I sending my samples? Can Manchester pick them up for us? Can Sheffield pick them up for us? Can we do this in an equitable state for all of our patients around the UK? And only by having this information can we demonstrate the inequality and move forwards and being able to find an answer and a solution. So treatments and trials, as you'll have all have heard from across the spectrum this weekend, this landscape of leukodystrophy is changing. I've been doing leukodystrophy work since 2016 when we were talking about, okay, what gene is it? How do we work out what the diagnosis is? We're now talking about how do we treat it? How do we manage it? Dare I say, how do we cure it? We might not be there for all of them yet, but that's the trajectory of change. And we're really proud as the UK network to be hosting lots of things here as a UK site, but also internationally having really good links. As a network, we need to up our game. We need to know what's going on and we need to show that we are a unified single service so that when industry comes to us, we are ready to support those trials, to provide those patients and to go forward with supporting our patients in that pathway before they're becoming NHS-approved therapies. And finally, we need to talk about research, training and education, because only by having research and training can we ensure that we've got medical professionals coming through that want to take on the mantle of the burden, but also the privilege of dealing with such families with rare disease and the complications that that comes with, but also the great benefits. We in the north of England run annual study days, and there's been really, really good buy-in from our local paediatricians, but our trainee neurologists, and now wider around the country. And we're looking at saying, how do we upskill? What is a leukodystrophy? I mean, how many families have had to answer that question 17 times over, and it's driving them absolutely bonkers to their doctor that's looking after them. So actually, what is it? What can we do about it? What can we do for you? But equally, what can your local team do? And this year, next month, we'll be hosting the treatable leukodystrophies with over 100 in attendance, which is amazing for a North of England service for a rare disease study day. We've got our whole genome negative pathway, which we've already talked about. And then, sadly, we've got a lot of lycra. So we had our first annual White Matter Family Picnic in Leeds earlier this year, that unfortunately included me running quite a lot of laps. So 45k we got to by the end of the day, but I'd also eaten a lot of samosas in the middle of that, which was quite enjoyable. But actually, we are a community, and providing that family community for children with rare disease is an important part of what we do. It can be extremely isolating to be given a diagnosis that nobody else knows about, has heard about. And yes, you might not all have the same diagnosis, but as been said today, there are a lot of similarities within that disease group. And if we can bring people together, and from settings like this, where we can work together to identify the challenges, to identify our commonalities, identify our goals with patient groups, families, professionals, industry, that's how we're going to make our service better for the future. So we've talked about research genetics. There are lots of discussions about new trials and newborn screening, so I'm not going to talk about that. We've got patient group involvement at weekends like this, but at other centres. And then the big setting for the next sort of 12 to 24 months is thinking about getting a working group together to set up those standards of care, those consensus guidelines for the UK, and then helping our service grow with those. And part of that is the patient registry, which is a job, thankfully, I do not have to drive. So I will hand you over to Rahul to tell you all about his headache of the patient registry. Thank you ever so much.
Thank you, Lydia. So just quickly, I've got to say, if anyone wants to have talk of research, the zebrafish are still in the other room. And I'm now going to hand you over to Dr. Rahul Singh.
Hi, I'm Rahul Singh, pediatric neurologist, very much involved with IWMD service development. One of the questions, we were in an important meeting, important disease, some new medications were in pipeline. And the question was, what is the incidence of this condition in the UK? There were a lot of experts in the room. We looked at each other, and we didn't have our own incidence and prevalence of that condition. When this service was being set up initially by NHS England, this came as a proposal, part of the service, that we needed to have a national service which will capture all the information, important data sets for patients with inherited white matter disease. And the aim for this service is to all patients, all ages, we need to enter the information in the registry. So it is a national service. It is a cloud-based application. It will be hosted by NHS England, and overarching objective is to maintain a registry, identify all the patients with leukodystrophies in this in the UK, have a high level of data completeness, and support the clinical management. I have seen so many of you doing this journey. Every journey is unique for you. The genetic condition you have is very much unique to you. We want to understand how it has affected you, how best we can provide you with the care you need. And as Lydia was saying, management of condition shouldn't be postcode specific, it should be condition specific. So we need to have a guideline. Children with Alexander's disease, we need to have some form of standard guideline, how we can do. And of course, the primary aim of this registry is to support the clinical care and understand the needs and how well we support them. I can keep talking about it, but in 10 minutes I wanted to show you the live registry. So, so this is the registry service will be led at Guy's and St. Thomas's Hospital, London. I'm leading the service, but it's not just me. We have to have this collaborative effort. And one big thank you to Alex TLC and Sarah. The amount of meetings we had to do, and it's still going on. I was told that the registry will be live before this meeting. So I was very happy. We might start entering patients' information. While I was driving to Birmingham, I got a call from NHS England. No, we need consent from at least 5 families to put in the data to begin with. So please don't enter the data. So service has almost gone live, but not gone live, and we will do that. Let me take you to the live link. It's not taking me to the live link. Yeah.
I might not be able to fix it yet. Is it on a separate screen? Yeah. Left or right, that's the question. There we go. That's it. Can't find my cursor on the other bit now. There you go. Can you, you can't see it there.
I can't see.
Sorry, I'm bring my cursor back. I'm just going to stop extending.
Just let's stop that presentation. Screen 2.
Where is it? The question. There you go. Sorry.
Yeah, this is the web page for IWMD registry. So this is the generic page, but when you, this is the home page. There is information for patients. How do you get involved? What is happening to your data? So all these information can be accessed by patients. What resource and support? There is a link for Alex TLC and Metabolic Support UK. And frequently asked questions section is there. You can download the document there. This will answer a lot of your questions about the registry. So there will be details of all the IWMD centers. This is a quality QA platform. It's not the live platform, but it's similar to the live platform. The Center for Adults and their contact details will be there on the on this page. And any update, any news, including Alex, this link will take you to the Alex TLC webpage. And then there is an option to register. You can register for the registry as an NHS staff. NHS staff doesn't have to be IWMD clinician. Your pediatrician, your pediatric neurologist would be able to register. And then you can register self as a patient and or a carer or representative. So let me log in as a So once you register, any one of you, there is a standard operating procedure for you to be verified who you are. There are some information we need to gather about the patient, so the system will guide you through that. So I'm logged in as a clinician. So based on your what role you have, if you are a clinician from IWMD center, you would be able to access all the data for your patients from that center. If you are a nurse practitioner, you have certain role-based access. So these are all the patients. These are not real patients. So what you see, this will take you, there are 7 sections. So there are certain sections which is accessible to clinician only. There are certain section which is accessible to patient. So you get a patient summary with demographic detail of that patient. Then there is a section where you capture all the key medical information, what you want to, which IWMD center they are linked to, where was the patient referred from. And it's quite, if you click into any of these sections, this is quite detailed information. When did your symptoms start? What was the age of onset? There are some, because this registry had to be for all the ages. So there are some disability scoring system. What was the clinical examination finding? So sorry. And then the MRI scan detail, genetic investigation, and what sort of current treatment you are on. So the details of different types of treatment patient is receiving, where is the place of treatment. So it's quite extensive. I'm struggling to show you all of them. And then follow-up medical information, all the subsequent visits and everything. So what I'm trying to say that moving forward from here, we will have information, clinical information, genetic information, MRI details, the plans of treatment, what level of supportive treatment they are getting, what is the standard treatment they are receiving, and in the treatment section you have there is an option if they are receiving any definitive treatment, gene therapy, advanced therapy. So all those options are there. And answering to some of the questions from previous sessions, yes, we are looking forward in future for all these new therapy, advanced therapy, gene therapies. But the core standardized symptom management plan is equally important. That has what impact it has on the quality of life, how best we can support them. So there are some disease-specific symptom management plan as well. So moving forward, that will be one of the aims of these IWMD service network, that we develop a standardized symptom management plan as well. And then I can log in as a patient representative. Let me try and see if I can log in. It's not working. So it's not letting me log in as a patient representative. So there are sections where if you are a patient or a carer, you would be able to register yourself and you can report how you are feeling. There are 5 domains in that outcome monitoring: your cognitive ability, your mental state, your physical ability, and and your day-to-day life, quality of life, scoring, everything is there. So this is not an alternative to your clinical management. If there is a clinical issue, that needs to be handled by your clinician. This shouldn't be an alternative of you have put some information on this that you had some fall or you wanted to see someone. This is not an alternative to that. But if we, when we analyze the data, we see that there is a particular region where there is some problem, that will help NHS commissioners commission the service, change something. So you have, as a parent or as a patient, you would be able to see those information. Any information you enter, the data manager of that center will be alerted that there is some new information there. If we need to contact your IWMD center, we will do that. And so it is quite an extensive registry and data collection service. And we hope that in 5 years' time, 10 years' time, we will understand our patients better, and we would be able to provide better care. Thank you.
So much, Rahul.